this afternoon is going to be a shorter talk, and I'm going to talk about some of the new therapies that are approved recently and that are on the horizon. And the first one are monoclonal antibodies. And it's kind of, I think, a little bit ironic that multiple myeloma is a disease that makes a monoclonal antibody. That's what your M-spike is. That's the antibody that you have in the blood of patients with multiple myeloma, and that it's taken so long for us to find a therapeutic monoclonal antibody with which to treat the disease. In fact, we wouldn't have monoclonal antibodies to treat cancer or to use for anything if it wasn't for multiple myeloma. The reason being that the way they used to make these antibodies, it was by using myeloma cells that they had growing in culture to produce the antibody that they wanted to use for therapy. And right now, there are two drugs that are antibodies that are approved for the use of treatment for multiple myeloma. And they're listed there, Elotuzumab or Implicity, and Daratumumab or Darzalex. And each antibody recognizes a unique target. So Elotuzumab recognizes SLAMF7 and Daratumumab CD38. So here I've shown you a schema for Daratumumab, and this shows you a myeloma cell. And on the surface of the myeloma cell, there's this target, SLAMF7. And the Elotuzumab can bind it, and it can then harness the immune system to recognize the myeloma and to fight it. And it can do that in different ways. One way is to attract other cells in the immune system. Here, there's a natural killer cell. It's a kind of lymphocyte. And it has a recognition site for Elotuzumab, so that we see some direct activation caused by Elotuzumab. And by that activation, it makes the Elotuzumab on the myeloma cell more visible. And when this activated killer cell interacts with the myeloma cell, it releases granules, enzymes, perforin, granzyme B. And so you're bringing this killer cell and you're putting it, and it makes it realize that the myeloma is a foreign target, and it destroys it. And so that's why we think there's a lot of promise in antibodies, because they're very, very different from all the other drugs that we use. And we think things like P53 may not mediate resistance to this kind of cell killing. So Elotuzumab was used in clinical trials as a single agent, and we did not see any responses. But when a phase 2 study was done, when it was combined with Revlimid and dexamethasone, the results looked really good. And so they went on to a large phase 3 clinical trial. Daratumumab, on the other hand, when it was used as a single agent, we saw responses. So just Daratumumab by itself is able to induce a response. And so we tend to think of Daratumumab as being a stronger or more effective agent than Elotuzumab. And what this slide is showing you are two large randomized phase 3 clinical trials where everybody in the clinical trial got Revlimid and dexamethasone, but then additionally, some people got either Daratumumab or Elotuzumab, and they were compared to the ones that didn't. So here you can see that the patients in this study, when they got Revlimid and dexamethasone, about 60% of them did not progress by 1 year. And in this study, same treatment, Revlimid and dexamethasone, about 57% of the patients didn't progress for about 1 year. And in contrast, if you added Daratumumab here, or if you add Elotuzumab here, you increase the number of patients that didn't progress. But you can see the control group here in these two studies is pretty comparable. The control group seemed to do the same. And obviously the treatment group here looks like they did better than the combination study here. So in general, we would recommend the Daratumumab, Revlimid and dexamethasone before the Elotuzumab, Revlimid and dexamethasone, depending on the clinical situation. So what kind of situations would make you choose one or the other? Well, I mentioned it earlier. And I think I might have a slide showing. Let's see if I got. Yeah, I have a slide showing it. So, but the kind of things have to do with the patient, the frailty, other extenuating circumstances where they are in their treatment course. So everyone is very excited because this curve looks so good. That curve, honestly, looks like a curve of what would happen when we treat newly diagnosed patients with multiple myeloma 5 years ago. And to see patients who are relapsed myeloma look like they're doing this well, it's like totally resetting the clock. It's very exciting. But is Revlimid dexamethasone key to this? So the study was also done with Velcade, bortezomib. And you could look where you say, well, this curve looks better than this curve, so obviously this is better. But that's dangerous and it's wrong. Because look at the green curves, which is the control arm. The control arms in these two studies are really very different. The patients in this study, when they got just Velcade and dexamethasone, only 8% of them didn't relapse at 1 year, whereas in this arm, 41% hadn't relapsed at 24 months. So why is that? And this has to do with clinical trials. You have different eligibility. A lot of these studies were done in Europe at a time when up front the patients in Europe were getting Velcade, but they weren't getting Revlimid. And so these patients were being treated with something that they may have had some resistance to. And so when you compare these results, you just look how much daratumumab added to what you got just with that. It looks like it even added more than there. So both combinations are really active and really effective. So whether you get the drug combined with Revlimid or whether you get it combined with Velcade, and we don't have a lot of data, but we think the same thing with carfilzomib, probably cyclophosphamide. We think it adds a lot to the disease activity. Yeah?
Does dexamethasone alone have any impact as sort of a booster on the daratumumab without either Revlimid or Velcade?
So
steroids play a role with the
it's interesting. When the initial study was done, when daratumumab was used as a single agent, the patients still got dexamethasone because one of the issues with daratumumab is reactions to the drug, allergic type reactions. And the way that the doctors control that is by giving them dexamethasone. But they gave them a relatively low dose of dexamethasone, and still daratumumab had good disease activity. Subsequently, in the other studies, they gave them higher doses of dexamethasone and the activity was higher, but the patients they were treating weren't as advanced. So it definitely has activity in the presence of low doses of dexamethasone. I suspect it probably has activity even without dexamethasone, although it's hard to give it without dexamethasone because of reactions. Yep.
After a few cycles, the patients seem to adapt and don't seem to have reactions.
That's correct.
Of course, everyone's anxious
No.
to not have it for the steroids.
Yeah. And so in general, I can say about my practice is as soon as a patient's shown a good response, and especially when the disease is plateaued, with every therapy, I tend to reduce the dose of steroids. And I generally don't continue them beyond a year in any case because of long-term complications from steroid use. But at the beginning, you want to use the best combination. So this next slide contrasts some of the differences between different antibodies that are used in myeloma. So I didn't mention this drug, Elotuzumab. We've got several clinical trials here. It's a CD38 antibody, just like daratumumab, and it's very active as well. It's not approved for use. It's only in clinical trials. And Pembro and Nivo, these refer to a class of drugs I'll talk about in a second. They're checkpoint inhibitors. And they're also not approved for the use in multiple myeloma, but they are approved in other cancers. So these drugs, you need to build up the antibody level in the blood. And so there's a commitment on the part of the patient that they need to come every single week while that buildup occurs. And it's for 8 weeks with Elotuzumab, and then every 2 weeks. And with daratumumab, it's 8 weeks in a row, and then every 2 weeks times 8, and then every 4 weeks. And the amount of time that you need to stay varies. Because people often get reactions to daratumumab, the first time you get it, we often need to stop the infusion and then start it again. We may need to give you Benadryl or Atarax, things to counteract chills or fevers or low blood pressure. And so this is sort of getting used to it the first time around that makes the first infusion relatively long. We see much, much fewer side effects with Elotuzumab the first time around, which is why we're more likely to recommend it to someone who's elderly or frail. I'll talk a little more about the side effects of these drugs. So they're just elderly, and there's an unusual pulmonary complication that can sometimes occur with people with daratumumab. So if they start off with respiratory compromise, that would also play into our choice. So we talked earlier about adoptive T-cell therapy, and this is a slide that explains it for those of you who may not be familiar. And what we're trying to do here is we do apheresis. We collect the white cells from a patient, and we activate the T cells in vitro, and then we introduce what's called a CAR, and that stands for chimeric antigen receptor. And so think of this as like putting an antibody on the outside of a T cell. So antibodies, are secreted in the blood, but T cell receptors, they stay on the surface of the T cell, and they recognize antigens. So we put this antibody, which is the chimeric antigen receptor, on the T cell, and now that T cell, it responds to wherever it sees that antigen for that antibody, like it was seeing a foreign antigen. And so we sort of trick the T cells to fight whatever we target it to with that antibody. And then these are, we try and remove the lymphocytes from the patient. We do that with some drugs like cyclophosphamide and fludarabine. And then we infuse those T cells back in. And this is in some ways on the same level like doing a stem cell transplant. This is aggressive therapy with complications that we've heard about. But it's effective. This is a slide from ASCO of a Chinese group that reported their results. In what you're seeing here is 35 different patients that they've treated, some of them that they only had just treated, and if they were this pinkish color here, they'd had a partial response. If they were a blue color, they'd had a very good partial response. That means a 90% reduction. And if they were green, that means they were in a stringent complete response. So everyone responded. And the patients that had been out the longest were all in a stringent complete response. That means they couldn't detect any disease. We don't know about MRD in this study. But so that's obviously very dramatic, and this was in China. We're all excited about the promise of this therapy. There are studies also going on in this country. This is from the group that really started CAR T cells in Philadelphia at the University of Pennsylvania, showing the first 15 patients. And here, in all these studies, the way that they're making the T cell recognize the myeloma is by putting an antibody to this thing, BCMA, stands for B cell maturation antigen. But it's a target that's uniquely on myeloma cells. And so now it's also on normal plasma cells. So the T cells recognize normal plasma cells and myeloma cells as foreign and attacks them. And we're basically seeing excellent responses. And this is a third study with the Bluebird. That's what BB stands for, another CAR. So these studies are they're coming to. We'll be opening up one here at Mayo Clinic. There's been one in Rochester for a while. They're hard to. They've been limited number of spots, so it's been hard to get a spot for patients. I think you may have heard that earlier. And also they come with complications. So here, death and death. So we're learning how to use these things and how to, obviously the immune system is great if it can control the disease, but we also have to be able to control it when we do these kinds of studies. This is another antibody that uses the same target, BCMA, but now instead of putting this on a T cell, you've attached a chemotherapy. It's got this funny name, I can't even say it. And that basically, you're taking a chemotherapy drug right to the tumor cell. And there's another drug similar to this that also uses the anti-BCMA, but you put something here that will bring a T cell. So instead of putting it on the T cell, you put a molecule here called CD3 that will bring the T cell. And so we call that a bispecific antibody. One side recognizes the tumor, the other side recognizes a T cell, and it brings the two together. And that's shown a lot of promise in acute lymphocytic leukemia. For little kids with leukemia, it's really cured a lot of them. And it may be that we can control that a little bit better than the CAR T cells, because this we can infuse it and then stop, infuse it and stop. The CAR T cells, you give them one time and then you just pray that everything works. So there's a lot of promise. And we have a study of both a conjugate with BCMA coming, as well as a bispecific with BCMA. This shows the results from that bispecific antibody. You see very good partial response, VGPR, stringent response. So clearly an active strategy. Now finally, I'm going to talk about checkpoint inhibitors. And these drugs have really transformed the treatment of cancer. Things like melanoma, renal cancer, lung cancer. These drugs are becoming frontline in those areas, or in some cases. Jimmy Carter, with his glioblastoma, received one of these, and he's obviously still doing very well. So what they are is schematized for you here. There's your cancer cell, and the cancer cell releases antigens that get picked up by other cells called antigen-presenting cells, and then the T cell recognizes these. But the tumor has got a way to make the T cell think that it's not a concern, and it expresses PDL1. It's this molecule that sort of turns the T cell off. And if we can block the signal between that and the receptor, which is PD1, then we can reactivate the tumor cell. We can basically take off the blindfolds, and the T cell can recognize, hey, you're a tumor cell, I shouldn't be ignoring you, and I'm going to fight you. And so it really heightens the immune system. And it's got side effects as a result. It causes autoimmune disease. Very common is to get thyroiditis, an autoimmune, and you may need to take thyroid supplements after that, which isn't a big deal. But it can have pulmonary complications, as well as other forms of autoimmune conditions. And so a phase 2 study was done looking at the combination. By themselves, these drugs do not seem to have activity in myeloma, but they've been combined with Revlimid or pomalidomide, and they appeared to be very active in our phase 2 setting. And as a result, we moved to a phase 3. And you might say, well, why do we need placebo-controlled trials, or why do we need randomized trials if the phase 2 looks so promising? And this is an example of why we really need the randomized studies. Here in relapsed refractory myeloma, this is the overall survival, and the patients that were randomized to receive the Pembro with Pom and Dex had a lower overall survival. And this is in newly diagnosed patients. And again, the same story. The patients who were randomized to receive the Pembro with Revlimid and dexamethasone had a lower survival. So both these studies, when you go into a randomized studies, they have a safety monitoring group that looks at this, and they looked. So the investigators don't know, but the safety monitoring group does know, and they looked at these results and they stopped the study because they saw that there was an excess mortality early on in one arm compared to the other. And as a result, in fact, all of the studies using these classes of drugs have been put on hold in multiple myeloma until we understand this better. This hasn't been seen in other tumors, and we think it, we really don't know. But the deaths appeared to be from toxicity, primarily, as opposed to from myeloma. And with that, I'll stop. Thank you.